I'll invite Dr. Rohit Shetty to kindly talk on corneal biomechanics and its role in selection of refractive techniques. He is a He is the one who has done the maximum work on corneal biomechanics over the period of time, and his experience and laboratory, especially in his center, is full of the equipment which can, diagnose all the, uh, biomechanics of the cornea very well. So, Dr. Rohit Shetty.
Mike. Thank you, sir, and it's been an honor and pleasure to be part of your IC. And thanks for giving me this opportunity to present a little ahead of time. So the talk today is about biomechanics and the role in selection of refractive procedures. These are my financial interests, drew research grants from these companies. When you look at importance of biomechanics from a perspective of refractive surgery, in theory it helps to make an informed pre-decision, better post-op assessment of stability. Definitely it's known to reduce ectasias, and there are enough papers and articles regarding how it can be incorporated into your clinics. So now we are looking at generation where you have a balance of corneal topography and corneal strength, the biomechanical strength. There are a lot of literatures on this. Basically, what I'm going to speak, the first machine to have come out was the ocular response analyzer. Fantastic tool. It gave an insight into the mathematical domain of biomechanics. But what really lacked was it was not able to connect to the topography. So when you were not able to connect to topography, a lot of challenges happened. So that's when the Corvus was able to connect to topography, and that's why you have indices like topography, topometric biomechanical indices, and Corvus driven indices, which is pure biomechanical indices. So that changed the whole dimension of refractive surgery. The biggest knowledge gap is to plan refractive surgery other than looking at the topographies, because there are times when topographies may look completely normal, but your topography indices looks abnormal. So these are like, here it's normal, everything is normal, but here it's abnormal. But you see here, even though the topography looks normal, your biomechanical parameters, which is measured by the CBI and TBI, is completely abnormal. Here the topography has some skewing, and your bad D is showing that there's some amount of element of suspicion, but your biomechanics is stronger. So these things completely puts you into a dilemma, and these things you need to be aware as you keep increasing, and this may have an impact on your growth in refractive surgery also. So there are various patterns which we need to understand. If you look at the topography, which is from Pentagon, the bad D, the CBI and TBI, which is the from the Corvus, and all are normal. This is absolutely a no-brainer, just works very well. But then you have a biomechanical being abnormal and the topography being normal. You have a topography being abnormal and the biomechanics being normal. And you have all of them abnormal. Even this is a no-brainer. 40% of our refractive surgery falls between 2 and 3 grades. And that 40% is actually the factor which is necessary for your growth in your practice, because you don't know what to do with them. And many times you push them for an ICL, but we all know ICL's limitations is your anterior chamber depth and other things may not be good in all of them. That's when we start looking at dividing them into different procedures. And whether you do a SMILE, LASIK, you add an extra procedure to it, or you do a transprearche to it, and that's when the whole thing comes in. For example, here is a case where your topography is completely normal, but your biomechanics is completely healthy. So these are the procedures. You can choose any of the procedures which you have planned, whichever you're comfortable with. But there are more indices. There are more indices which looks at stress strain and SPA1. SPA1 is how the, even before the cornea indents, the response of the cornea to air puff. This is called the stiffness parameters. For me, it's one of the most important indices which is not part of the main reading of a map, but it's there, it exists in there, so I do use a lot of them. So what I do is in my practice is to build a more organized way of it. We look at IOP is very important because entire biomechanics depends on IOP. If you have an IOP of around 25, you have to just forget about biomechanics because biomechanics behaves completely different. So that's why in your pattern, you have to understand the biomechanics is important. When your SPA1 is normal, very low, then, with this kind of cases, when you have a corneal biomechanics being suspicious, you consider a phakic lenses. So you look at the biomechanics, you look at the SPA1, and when the SPA1 is stronger, more than 100 is always stronger, then you can look at PRKs or smile extras or one of these procedures. But when it's very low and everything has an issue, then just don't do anything, just think about an ICL. So again, it gives you an insight into planning in a more organized way. So the role of topography is very important. Here, your biomechanics is normal, but your corneal topography is abnormal. This is a very interesting thing because why should the biomechanics be normal and the topography, why should the biomechanics normal and topography abnormal is because the epithelium makes your cornea to have an inferior stapling, and that can be picked up as a bad D being abnormal, but your CBI, which is the pure biomechanics, is completely healthy. So using epithelium also is very important when you try to look at how your biomechanics looks at, and based on that we can again plan our refractive surgeries and decide. So biomechanical parameters helps me to plan a bespoke treatment for my patients. When I say bespoke, it's about whether you do a PRK, whether you do a smile or a smile extra or a ICL. Otherwise, what happens is everything is based on just the topography, which is probably not right in today's context. So role of epithelium is very important because if you just use topography, the epithelium can induce all kinds of topographic abnormalities, and that's very, very important aspect, which you can probably negate it by looking at the biomechanical parameters. So we wanted to see if we can predict the outcomes, basically trying to figure out how do we reduce the corneal, what procedures would change the corneal strength. So that's how we looked at the finite element modeling. If in the aeronautical industry or people who makes the truck or car, all they do is they create crash simulation, not by crashing a real vehicle. They create a crash simulation by using a finite element modeling. That means you create a model and you use force to create the change. So our team used the same principle of topography and biomechanics and build a model called as AIOC, which is again creating a artificial simulus. It's called a finite element because each of these boxes are an element. It's of a finite value. And you can use different pressures, you can create different surgeries, you can create different inlays, you can do whatever you want, you can create extra procedures. And this is a software. If you have both these tools, I can share this software with you, you can use it in your practice. And what happens is if you add all this data, which doesn't take much, it runs a simulation AI driven platform and it gives you this report. And what it gives is, it gives in newtons per meter. It will tell you post surgery how corneal ectasias, which we could get the data of pre-op from all over the world. We have more than around 30 patients across the world who had a pre-op biomechanics, and how did the machine predict it, and made the machine to build an AI on it, and this is what we get. And this model gives you a very good prediction about, if I do a LASIK, I get 6 newtons of weakness. If I do a PRK, I get 3. If I do a smile, I get 6. So I can choose which one will be the least amount of stress on my corneal structure. There's a lot of areas now on LALEX or ClearLEX procedures. We looked at the OPL, opaque bubble layer. We built an AI platform on this. And what we found was in 78 to 80% of them, the biomechanics was able to predict the amount of OBL created by any machine, whether ATOS, Silk, or any of these techniques. The ease of dissection was able to predict. Again, the same AI model. This is not so great, but we are reaching there. Around 60-65% of them, we were able to see how ease of dissection which can have with the particular energy setting, which is very good, because if I had to train or the new person is getting into this, I can plan which case to give it to him based on the ease of dissection. The future is going to be optimizing the track and the line distance, the laser spots, all the energy settings today you can manipulate for all the machines, including Zima. And you can manipulate based on what type of a corneal strength you have, whatever Young's modulus you have. And these are the areas where I can choose whether I need to do an extra procedures on my patients. So in summary, biomechanics is not just a tool to look at yes or no for surgery. It's a personalized pathfinder. And when I did the in vivo confocal microscopy of ease of dissection, I found that ease of dissection has a huge implication in the quality of vision day one, and that for that the biomechanics played a role. And how does this corneal tissue responds to a particular stress? I think it's a very, very big area of interest. We call it as a bilex, biomechanical implanted lenticle extraction. So this is a very important concept, which probably will be where the Corvus will have a huge role in the future. Thank you.
Thank you, Dr. Rohit, for this wonderful talk and making this very difficult subject somewhat easy to understand. And I think, yeah. So, Dr. Upesh, you wanted to say something.
Most of the centers don't have the biomechanics machines, but we do have the epithelium mapping tool. So will it be of some use if you don't have the biomechanics and epithelium mapping?
So if you have a topography which is very abnormal, and if your epithelium is also very irregular, that means the topography being weaker is not a true weak.
Okay.
That gives you an indirect sense. So that means you can think about doing a LASIK. Or many times we see a bad yellow or a red, we just ignore it.
Yes.
But if epithelium is very inferiorly, it's a huge epithelial thickness. That means it's not biomechanically weak, it's just that epithelium is making it look like it's weak.
Look like. Okay. Thank you, sir. Thank you, sir. Anybody else? Dr.
Any
Bajaj?
questions? Okay. Okay.